stuff. Good evening, everyone, and thanks for attending. It gives me great pleasure to present our speaker for tonight is Professor Quentin Anstee, and he's been with us. He's been with Newcastle since 2010, roundabout. I can't believe it's that long, but it is. And we are extremely privileged to have him in Newcastle as a hepatologist and also as a principal lecturer. He's absolutely gifted, and he's done some brilliant training at King's College, and he's only written 200 publications. So apart from that, he's been the speaker of choice at over 40 international conferences. So, in fact, you're lucky if you have an appointment and you can get Quentin Anstee, because he'll be out of the country somewhere talking to somebody else. Now, I can ask you all to mute, and then at the end of it, we'll have questions and answers, hopefully. But I never asked Prof. Anstee, have you got any slides for this talk?
Yeah, I've got some slides, so I'll bring those up now.
Well, I'll make it available to you. There, I made it available now. So when you want to show your slides, you should be able to. So it's over to our friend, our supporter, and our principal hepatologist and speaker for tonight, Professor Quentin Anstee.
Brilliant. Well, thank you very much indeed, John, for that very kind and generous introduction. And it's also great to see so many people on the call. There's been a lot going on in the world of what we formerly knew as non-alcoholic fatty liver disease over the last few months. So it just seemed like a really good opportunity to update people on the new nomenclature and also talk a little bit about some of the developments in terms of clinical trials and therapeutics, because again, a lot of exciting progress there. So with that, I will share my screen. Hopefully everybody can see those slides. Yeah, okay, great. So can I talk a little bit about this new name, MASLD, and as I mentioned, also about therapies. Those are my disclosures. So it's fair to say that any treatments I talk about, any pharmacological treatments, currently there are no licensed treatments in the UK, so everything I'm talking about is experimental. So we're all very familiar with what we used to know as non-alcoholic fatty liver disease and the progression to steatosis or NAFLD, then on to steatohepatitis, NASH, and in some individuals, cirrhosis and beyond. And we were comfortable with that idea of an umbrella term of NAFLD. There were, however, some challenges with this name. The first is that it's a negative definition. In other words, we tell you what you don't have with the name rather than tell you what you do have with the name. There were also some concerns raised that there were elements of non-alcoholic fatty liver disease that, at least in the English language, were quite stigmatizing. So the idea of alcoholic somehow implies that maybe alcohol might have been the cause for this. And then the issue of fatty, which turns out not to be so much of a problem in other languages, but in the English language has that connotation of sort of the schoolyard and teasing and abusing each other and so on. So there were lots of reasons why maybe it was time to think of a change. And this is the new nomenclature that's come along. So NAFLD has become MASLD, metabolic dysfunction associated steatotic liver disease. The idea being that it's now a positive diagnosis. We're telling you that it's caused by metabolic dysfunction. We're not telling you that it's not caused by alcohol. And then we're using steatotic, which is the sort of official classical name for fat accumulation, rather than fatty, which, as I've mentioned, may be a little bit stigmatizing. So that's the new terminology. But what I thought I'd do now is just talk a little bit about how we got to that, why we got to that, and I'd be happy to discuss it with you, because at the end of the day, what is in a name? a rose by any other name would smell so sweet. So really, has this been a period of wasted effort, or was this a useful exercise for the field? And I think that's a very fair question, and something that it is worth us reflecting on. So how did it start? Well, it all started a couple of years ago, back in 2019, before COVID-19, when a number of us started to write papers really discussing what was wrong with the current naming. This wasn't about stigma at that point, although we were aware that was an issue, but it was about whether it was a good way of defining the condition. There were also questions about the fact that we know in the real world that being overweight, diabetes, high blood pressure, high cholesterol, all of those things are very common in our populations. And so then there's the question about, well, they coexist. For example, they coexist with alcohol consumption. They may coexist with other causes of liver disease. And so was this negative terminology the right way to approach the disease? And there was a suggestion which was put out initially as a straw man approach of MASLD. The idea being that it was about having evidence of diabetes, insulin resistance, carrying too much weight, but also alcohol could be contained within that same disease diagnosis. And that was really put out as part of if you like, an academic exercise to discuss it and to think about things a little bit more. And what followed in the medical literature were a series of further articles weighing up the pros and cons for this. Yes, maybe it's time for change, but what are the downsides? What are the ramifications for it? After that, something quite surprising happened. The literature split, and there were a series of papers which were very cerebral, thinking about, well, is there a downside to making a change like this? What are the issues with it? But then there was this frenzy of early adoption with a lot of studies coming out. And this actually became an incredibly polarizing subject in the medical literature and indeed at medical conferences, with people really forming into two camps. And so it was necessary to bring some, cooler heads to bear and to actually think about this a little bit more. And part of the reason for that is that we know that, and I'm taking alcohol consumption here as an example, we know that there's an interaction between the metabolic syndrome, diabetes, high blood pressure, etc., and our alcohol consumption. And so even within the standard range of, 1 to 2 units of alcohol a day, if you also are overweight, if you also have diabetes, your risk of liver-related damage goes up dramatically. And so this idea of combining alcohol consumption and non-alcoholic metabolic liver disease all together in one pot was potentially quite difficult. It would actually change the disease. It would alter the biological processes that are taking place in the liver, and it might actually change how our non-invasive tests actually function. So the feeling was we needed a Janus-faced approach. We needed to find a way forward that gave us a name that wasn't stigmatizing, that gave us a positive definition of the disease, but which allowed us to retain the last 10 years of research or the knowledge that has been built up, and not to throw away that information. And so I'll skip over that one for now. And so really we needed to start to unpack the concepts of fatty liver disease. It wasn't just a name, it was also a disease definition. And it's okay to change the name, but we have to be very careful about altering the definition of the disease and the unintended consequences for that. If you think about it right now, we have dozens of drugs in trials for fatty liver disease. If the actual definition of the disease changes, it means that by the time the results of trials get read out, the disease that we'd be treating would no longer be the disease that was then being diagnosed in clinics. And so you'd have medicines potentially licensed for a disease that in that current form does not strictly exist. And so it was very important to spend time thinking about this and come up with an objective way forward. And so the large international professional societies convened a steering committee, and you can see mugshots of a number of us there. And this was led by the European Association for the Study of the Liver, but also the American Association for the Study of the Liver, the European Liver Patients Association, and their counterparts in North America. So it really was as holistic and as multi-stakeholder as possible. We went on and we've established a multi-round Delphi process to try to answer a number of key questions and to really bottom these out. What were the issues with the existing nomenclature? Were there issues with it? How should we define disease endpoints? How should we capture that concept that alcohol may interact with the metabolic syndrome? And then, of course, there are questions about, for a long time, fatty liver was really an orphan disease. There was very low awareness. We've just started to get some awareness. Is now the right time to, change the name altogether and move away from it? So there were a lot of live questions there. But it was also an opportunity to recode the condition so that we have a better way forward that will grow with us as we understand more and more about the biology, about the factors that are actually at play in the liver. And as new discoveries come on, maybe new genes, maybe other aspects about the biology. So it was also an opportunity to build a nomenclature that would allow us to learn and expand, grow, if you like, with our knowledge. So there were several rounds of this Delphi process. To be honest with you, it felt like it was never going to end. As we tried to pin these down. And you can see here from the final publication, some of the factors that were considered, both those which were impacting the name, whether it was the right time, how we would change the name, what would be an appropriate acronym to use, and then also factors affecting the definition. Alcohol, I keep coming back to it because it was a really important thing. And if you think about our society, alcohol consumption is endemic. It's entirely acceptable within Western society. And so we know that these conditions, to a greater or lesser extent, there are behaviors that are coexisting in all of us. So we needed to capture something that dealt with all of that. And what came out of the end of that process is this new nomenclature. So you start off with an overarching name, steatotic liver disease, basically liver disease due to fat accumulation within the liver tissue. And then we can go down from that and start to carve out distinct subcategories. So the one that we're all now becoming more and more familiar with is the one on the far left here, metabolic dysfunction-associated steatotic liver disease. That is essentially NAFLD, as we all know and love it. And then the subset of MASLD, which is metabolic dysfunction-associated steatohepatitis, MASH, which, of course, was NASH. So that is very much the same condition that we've all previously been familiar with. At the right green box, you can see the other extreme, alcohol-related liver disease, or ALD. And of course, we know that whether it's through being overweight, high blood pressure, high cholesterol, or whether it's through high alcohol consumption, when you actually look at the liver down the microscope, they look virtually identical. And so all of these fall within that spectrum. And then in the middle, this mixed category, metabolic ALD. So it's that overlap where basically people have metabolic risk factors, but also drink slightly more alcohol than the recommended 14 or 21 units, up to 50 grams or 60 grams per day. So increase to 5 or 6 units of alcohol basically. And it's that sort of middle ground. We know it's at about 50 grams of alcohol where true alcohol-related liver disease starts. But what we also recognize is that if one has multiple metabolic risk factors, as I've shown you, and I'll flick back just to highlight this again, as you can see here, if you have these metabolic risk factors, that risk of liver damage starts to increase long before you reach the top end of what was previously considered to be safe amount of alcohol. So this middle category is very helpful in that respect because it allows us to capture this idea and to move away from what was this rather uncomfortable oxymoron of coexistent non-alcoholic liver disease and alcohol-related liver disease, which was always very uncomfortable when you had to try to explain that. So this gives us a more sensible home. At the right-hand end here, there's also the recognition that there are other less common causes of fat accumulation in the liver, specific rare genetic variants, medication that can cause fat accumulation in the liver, and then we also recognize that there will be further discoveries in the future as we start to subcategorize metabolic dysfunction, MASLD, MET-ALD, and ALD, and understand further modifiers with it. And so we now have a very nice diagnostic process that starts off identifying whether or not there is fat accumulation in the liver, in other words, the presence of steatotic liver disease. It then asks the question, does a patient meet any cardiometabolic criteria? And I've put those on the right there. Basically, a body mass index of greater than 25, presence of raised fasting glucose, in other words, a diagnosis of diabetes or being on treatment for diabetes, high blood pressure, high triglycerides, or low HDL cholesterol. And if at least one of those is present, then we move down to the next question. In other words, is this MASLD or is it MET-ALD? Or if there's extremely high alcohol consumption, then ALD present. And so we have this logical pathway. And that's very helpful in terms of ensuring that we diagnose the same condition, whether you come to see me at the Freeman, whether you go down the road to the University Hospital in Durham, or whether you're somewhere in France or Germany or America. We're all now operating via the same diagnostic criteria, which it may surprise you to know was not always the case before that. So it's an important point. And this new nomenclature also allows us to begin to see this gradation of risk and recognize that we're not, it isn't one size fits all. Each of us has different genetic factors at play, different lifestyle behaviors at play. So some of us may be more sedentary, others may be more active. Some of us may make certain dietary choices, others may make different dietary choices, and some of us may consume more or less alcohol. And all of these factors combine, and so you get this rather nice heat map, if you like, of risk of progressive liver disease and decompensation, which we can start to populate as things go forward. This new nomenclature has now been endorsed by societies globally. You can see a number of them here. So in the UK, BASL, the British Association for the Study of the Liver, and the British Society for Gastroenterology have endorsed it. I think also LIVErNORTH and the British Liver Trust and so on. So it's great that there is this level of buy-in, but as you can see, it really is an internationally endorsed process. I said to you at the start of this that one of the important things is to check that changing the name, changing the definition in any way doesn't mean that we find a different group of people. And there have now been a couple of studies published which demonstrate that indeed NAFLD and MASLD really are finding the same people. So this was a very nice study coming out of a large Swedish population that did it. And this was a study I actually just pulled together for a presentation where we went back to the European NAFLD registry, which of course we recruit to in Newcastle, and people in LIVErNORTH, many of whom have very kindly agreed to join the cohort studies, and to actually just take 1,000 people at random from the registry, which is now over 10,000 people, and just run through the definition of MASLD to check that, did we find the same people each time? And the answer is 98% overlap between the old NAFLD definition and the new MASLD definition. And it to be honest, doesn't get better than that. That in the real world, that is, essentially complete overlap with the two. So very reassuring that this new nomenclature isn't going to alter our understanding of the disease. It isn't going to change how our non-invasive biomarkers that we've been working on in litmus will actually perform, and isn't going to undermine the development of new treatments. So I think that's, as I say, quite reassuring. And I'm looking forward to discussing that with everybody in a few minutes. But I thought I'd also just briefly update you, as I've promised, on some of the developments in terms of the treatment of MASLD and where we are with that now. So, of course, and we've already alluded to this, underlying MASLD is this incredibly complex physiological, sociological, cultural, economic model that is driving all of us to be slightly more overweight than a generation before and a generation before that. And that is the driver of MASLD. And so the best treatments, of course, break down into 4 steps. And we've talked about these before. Number 1, diet and lifestyle change to try to bring weight down, in other words, targeting obesity. Number 2, using medicines to control the metabolic syndrome and reduce cardiovascular risk. Number 3, targeting the liver disease itself to try to get rid of the inflammation, the scarring in the liver. And finally, number 4, reducing downstream complications like liver cancer. So if we just go through those one at a time, number 1 then is that lifestyle change. And John and I were chatting just before the call started. This is that first edition of the LIVErNORTH Lifestyle in Your Liver booklet that we wrote all the way back in 2015. And it's really edifying to see how widely it's been adopted, and how it's being used by patients in the community and by colleagues in hospitals when communicating these concepts. Of course, it's also equally exciting that a new edition is in the pipeline, updated with the latest nomenclature and with some further information. But what we know is that weight loss on its own, whilst this works, if we get 5% of our weight off, fat leaves the liver, 7% we reduce the inflammation, 10% the scarring begins to heal. Whilst that is good news, we know it doesn't work for everybody. And you can see here on the right the percentage of individuals who achieved weight loss goals greater than at least 5%, but didn't get the histological improvements that you might expect with that. And so we know that whilst lifestyle change has to be a key fundamental part of our treatment for fatty liver disease, it probably isn't enough on its own, and that we are going to need adjunctive therapies, pharmacological therapies to help us. Now, as I've mentioned, there are no licensed treatments for MASLD in the UK at this time. And in fact, if I'd given this talk a month ago, as I have with LIVErNORTH before, this slide said there are no licensed pharmacological treatments, full stop. And that's changed. And that is one of the most exciting developments I think we've had so far this year. So the fundamentals remain the same, that we need to control the obesity, reduce cardiovascular risk, recognize that statins are safe in people with liver disease, and we should be using those. But where things are changing is that purple quadrant, the targeting MASH. Before we talked about maybe vitamin E, we talked about maybe some of the diabetic medicines like pioglitazone, but there are now a number of other treatments, most of which are in trial, but are targeting specific pathophysiological process, specific parts of the biology of the disease. And let me just very quickly break this down a little bit. So at the one end of the spectrum, we know that insulin resistance and fat metabolism within the liver is one of the drivers of MASLD. We know that that leads to what's called oxidative stress, which is a chemical reaction that damages cells. And that in turn leads on to inflammation and activation of the immune system within the liver. That in turn causes the death of cells within the liver. And following that, there is a wound healing response that leads to scarring. And it is that scarring that forms cirrhosis. So each of these can be targeted. There are metabolic targets, anti-inflammatory targets, and anti-fibrotic targets. And if we start off thinking about the metabolic targets, this is one of the areas where there's been the most research in terms of medicines. We have GLP-1 receptor agonists. Now, those I'll talk about in a moment. They're already licensed for the treatment of diabetes and obesity in the UK. But now the question is, might they also work for the liver itself? There are PPAR agonists. Now, these are medicines that are actually related to drugs like fenofibrate that used to be used, still is used, to treat high triglycerides, in other words, abnormal cholesterol levels. But we can also use other combinations of the agonists for different PPAR receptors to treat fatty liver disease. There was a lot of work on FXR agonists, so that was obeticholic acid, and I'll mention that a little bit more. And then bringing us right up to date, these thyroid hormone receptor beta agonists, which, if you like, are like pressing the accelerator on our liver metabolism to burn up fat. So, number of potential targets here. There have also been some drugs trialed that are anti-inflammatory or reduce cell death, and some that are directly anti-fibrotic. However, the ones that have been most successful so far are the ones that are focusing on those metabolic targets. These are the 5 that certainly up until quite recently were the most advanced, and I'll just update you on them. So obeticholic acid, the phase 3 trial actually read out last year and showed significant benefit in the liver. Then there's resmetirom, that's that THR beta agonist. Again, that trial read out just before Christmas and again showed positive effects. Semaglutide, that's the GLP-1 agonist. It's already licensed for diabetes and obesity in the UK. And then these experimental agents like lanifibranor and aramocol, which are still in trial. Obeticholic acid was taken to the FDA last year by the company that was developing it, and the FDA felt that the risks of that particular medicine were outweighing the potential benefits for it. So the development of obeticholic acid for fatty liver disease, for MASLD, has now been discontinued. So we can take that one off the list. The exciting news, and the thing that only happened a few weeks ago, was that resmetirom, THR beta agonist, was taken by the company that developed that one to the FDA, and the FDA has now approved that drug for marketing in the United States, which means that as of today, people are being prescribed that medication to treat MASLD in the United States. And that's the first licensed medication in North America for MASLD. So that's a really important step. And we're now waiting to see whether the European Medicines Agency and the MHRA in the UK will also license these treatments. So important step. Then, of course, we have semaglutide. As I've said, it's already available for other indications, and there are studies ongoing, and similarly for lanifibranor, as well as a range of other medicines that have entered trial that I haven't got time to cover today. But let's take a moment to just talk about THR beta receptor agonists. So that's this resmetirom, but there are several others, which I've listed on the slide there in the bottom right, also being developed that are very similar agents. And what we know is that turning on this thyroid hormone receptor beta, it lowers bad cholesterol, so HDL cholesterol, so it gives a potentially cardiovascular beneficial profile in terms of heart disease risk, which is very good. But there have been now several studies looking to see whether this agent is also beneficial for the liver itself. In total, now over 1,500 patients across these various different studies have been exposed to the medicine. And what's very nice is if we look at the data from what was called the Maestro-NASH study, we can see that it was significantly better than placebo for the two key endpoints that the FDA and indeed the European Medicines Agency require. The first is resolution of what was NASH is now MASH, and you can see here that about 30% of individuals treated with the higher dose of resmetirom had an improvement in NASH versus just 10% in the placebo group, so about a 20% over placebo improvement there. And if we look at fibrosis improvement by at least one stage, that would be F3 going to F2, F2 going to F1, we can see that again, about 25–26% of individuals treated with resmetirom had improvement versus about 14% on the placebo arm. So around about 10% greater than placebo change, along with those beneficial changes in cholesterol. So a medicine here that is now licensed in the United States, but not yet in the UK or Europe, that is showing improvements in terms of those key factors that we look to see, reducing inflammation, reducing fibrosis in the liver. Very exciting news. It's not the only medicine, however, that's being developed, and these are the others. Semaglutide, as I've mentioned, which is widely used to treat diabetes, but there is a range of other what are called incretin mimetics being developed. We know that many of these agents have very good effects in terms of reducing all-cause mortality, reducing cardiovascular mortality, and the question is, do they also help with MASLD? Here's data for semaglutide demonstrating how people lose a substantial amount of weight, up to 12% of their body weight over 72 weeks, how it improves their insulin resistance. And then when we look at the liver itself in a phase 2 study, we can see that there was a statistically significantly greater improvement in MASH, in other words, MASH resolution in patients treated with that agent over placebo, although over a 72-week period, that didn't read through to showing improvements in scarring of the liver. But the message here again is that we're seeing agents that are potentially beneficial, and now further data in phase 3 studies is needed for semaglutide as an example. There have also been a number of other agents, and this is one called tirzepatide, which is an even more potent weight loss agent. Individuals here losing, I think it was, I can't remember now, well over 15% of their body weight. So substantial reductions. And as you can see, if you look at the scans of the liver in the bottom right-hand corner here, those reddy colors indicate fat accumulation. The blue colors indicate fat leaving the liver. And you can see here that over that period of time, a very steatotic liver loses that fat infiltration. And that speaks to the power of these agents in improving insulin resistance and helping the weight to come down as well. Then lanifibranor, that's that PPAR alpha delta gamma agonist. Again, and I'll go through this very quickly. It's a combination medicine, really, in that it has those effects associated with improving cholesterol, but also effects associated with improving insulin sensitivity and so on. And the phase 2 study again demonstrated improvements in MASH activity as well as improvements in fibrosis. And that's very exciting data, again, now in phase 3 studies. So watch this space. What I'm basically saying here is we now have a number of very promising agents at different stages in trials. The way trials work, though, is you have to take a single agent targeting a single point in this very complicated disease biology and see if that works. But with so much complexity here, and if you look at all the different arrows on this picture, you can imagine different ways of bypassing a block anywhere you might put here with a particular tablet. The question then is, will a single medicine be enough? Or do we actually need combination therapy where it will be lifestyle change in terms of diet and activity? It will be not just one medicine, but maybe 2 or 3 medicines. In the same way that people with diabetes may be treated with metformin and gliclazide, or people with high blood pressure may be treated with a beta blocker plus an ACE inhibitor, in those combinations, do we need to be doing the same sort of thing and combining medicines to treat MASLD as well? My own view is that probably yes. Ultimately, it won't be a single agent that is needed. This disease is far too complicated, and there may well be different medicines needed at different phases as the disease progresses. So, and that's what I've tried to capture on this picture here. You can imagine that situation where early in the disease, where there's very mild fibrosis, really there you want to focus your medication on something that reduces the fat from the liver, that reduces the inflammation from the liver, and it's something that potentially somebody might be on for a very, very long time. So you need it to be incredibly safe and to be very, very well tolerated. Then, of course, at the other end of the spectrum, when you have cirrhosis, our tolerance of risk may be a little bit higher. We always want a safe medicine, but if you've got very advanced liver disease and the liver is at the risk of failing, maybe they're a more potent agent, which possibly has some side effects, may be acceptable to people if it is also very effective at breaking down that scar tissue and reversing the liver. It's a personal choice, and this is hypothetical, what I'm showing you here at the moment, but I think this is likely to be the direction we travel to, where we're using different medicines alone or in combination, and different combinations at different points in a patient's journey as the disease progresses. So I'm going to conclude there. I hope I've given some food for thought, but also left plenty of time to discuss, because it'll be really interesting to hear other people's thoughts. Just to conclude, I think we all know MASLD is highly prevalent. I hope I've explained the rationale between behind the new nomenclature. It's not, they're not names that trip off the tongue. I'm going to be completely honest, and I think you've probably noticed even during this lecture, I've reverted a few times to talking about fatty liver. It's just old habits die hard, rather than some subliminal message that I don't ascribe to the new name or anything along those lines. I think the new nomenclature has a lot of positives to it in terms of the logic, a unified diagnosis, and also that removing those potentially offensive or stigmatizing words that nobody ever wants to do. I also hope I've shown that there are some really exciting developments. Many people on this call have taken part in trials over the years, contributed to the knowledge that has got us to this point. We still need to keep doing more studies. Even that drug that has now been licensed by the FDA at 25 to 30% histological improvement, that still leaves 75, 70% of individuals not gaining benefit from it. So we've still got a lot of work to do, but it's a great start. John, I'll leave it there. I just want to acknowledge my funders, my many colleagues in the lab, in the hospital who work with us, and of course the support of LIVErNORTH, who've really helped me with my research program in Newcastle and guided how we've framed things like the NAFLD registry and the advanced study that will be coming up as well. So thank you all.
Thank you so much, Quentin. That was absolutely brilliant. I couldn't possibly repeat it. And thank God it's been recorded. Um, I've got one question before we open it to other questions. I mean, the new treatments are really significant, really exciting, and it's everyone who's had a diagnosis will be listening to your every word, and getting heart from it. But how do the FDA, how does it end up as being approved in the UK, and how long does it take? And that's the question.
So whenever, I mean, not just this disease, but any medication, any new medication is assessed by NICE. So it's assessed by two agencies, the MHRA, which is basically, is it safe? Is it effective? And NICE, which then comments on, again, is it effective and is it cost effective? Because there's, and this concept of quality adjusted life years, the idea being there are, medicines that might help a little bit, but they're so insanely expensive that the NHS could never afford to pay for them and things like that. And that's what NICE assesses and makes a judgment on. So what we're waiting for now is that the company that developed these medicines needs to get them approved in Europe and in the UK. So through the regulators, that's the EMA and the MHRA. And then they need to have discussions with the payers, that's the NHS, that's NICE, to see if the payers are going to pick up the cost of those medicines.
Yeah, will the drug companies be the driving force behind this? I mean, they want to sell them, obviously, so they'll be pursuing it. They'll be pushing to get them adopted in Europe and in the UK. Yeah.
I would imagine. I mean, I can't speak for the companies, but yes, that would be what I would imagine. It's understandable they go to the United States first. It's a huge market for them, so it makes sense. But I think the next step is the socialized healthcare systems of Europe, and it's a very different conversation. But that's a good conversation, and NICE does a fantastic job getting medicines to us. Yeah.
Thank you. So, has anyone got any questions for Prof. Anstee, please? Yes, Yvonne. Yeah, excellent. Can you unmute, Yvonne?
Yeah, thanks very much indeed, Prof. Anstee. It's was fascinating. By Jove, it's a lot to take in, and that's for someone who does come to visit you and see you very regularly as well. So thank you so much for that. I just wondered, I know you've spoken a great deal there, and but in terms of the advanced study, I mean, if you could just briefly mention how the advanced study, how you see the advanced study working for patients, if you understand what I mean.
Sure. No, absolutely. So just to take a step back, the advanced studies is a different kind of question. So everything I've talked about there, if you think about any one of those medicines, the reason we have that medicine in trial or that medicine has been licensed is because 5 years, 10 years before that, research was done in a lab somewhere that identified a biological pathway active in the liver as the disease gets worse, and then developed a medicine to target that pathway. So what advances is it's about that question. So it is understanding what are the biological pathways active in the liver in patients with cirrhosis caused by MASLD, so that we can hopefully find new ways, new points, new pressure points in that biology, which can be targeted with new medicines. So it's a slow burn investment. It's discovery science advance. And what we're needing there is the help of patients who are going to contribute, allow us to take a sample from their liver so that we can take that little piece of tissue back to the lab, and we're going to spend serious money and serious time unpicking all the different metabolic pathways, understanding everything that's going on, literally cell by cell, so that hopefully we can find better ways of reversing cirrhosis in the future. So thank you, Yvonne. I mean, that's a great question, and that's what it's about. It's that first step on the journey that hopefully one day leads to another treatment that gets that 70%, which is still missing, even with the best of the medicines we currently have.
Yeah, it's particularly important for me in terms of my own daughter, you know, how things genetically, there's a predisposition to things happening to you in a sort of a genetic way. And that's always fascinated me. So I see this opportunity, the advance is a great way forward in terms of, and I'm pretty certain I might be one of the ones that you sign up. I don't know, but I don't want to put you on the spot now.
Well, I'm not allowed to talk about that in that
No.
sense until we open, but
Yeah. No, well,
I'm very open to anybody who wants to come forward when the time is right.
Yeah, yes, I know that was something that was put out in the local press as well. People putting themselves forward as well. But yeah, so thanks ever so much for that. Anyway, thank you.
No, thank you.
Excellent. Any more questions? I know it was very complex. And Prof showed you this booklet, didn't he, wherever it is? How can I get this in focus? There, can you see it? It's our booklet on lifestyle and your liver, which is currently being rewritten. And it's been backwards and forwards a couple of times to Prof's team, because we find it hard to put it into plain English, the explanation that Prof's just given everyone. So when it does come out, it will be easy to understand, hopefully, so that people will know the difference between all the different stages or steps or diagnosis. And that's what we're trying to get around, trying to make it, you know, easy for everyone, especially people who haven't got English as a first language as well. Remember, we sometimes translate these documents into other languages, and it would be a nightmare for somebody to try and translate that one. So we're doing that now. Did you want to say something else, Yvonne? Your hand's still up, or you're just waving to us? Very good. That's
John,
it. Yes, John, thank you.
I'm sorry, I don't know how to put my hand up other than.
Well, you can do that. You can just do that.
I see, right. Well, I just wanted to say thanks to Prof Anstee for explaining something extremely complicated in what I thought was a fairly easy to understand way. It was very interesting, and it's also very pleasing, I think, that strides are being made. But my question is, one of the issues that I had when I first went to Prof Anstee was that I was diagnosed with NAFLD or MASLD quite late, because it was asymptomatic. And I'm just wondering, I know I'm going to the other end of the process, I'm just wondering whether any advances have been made in improving the early diagnosis.
No, thank you. That's a great question, and it's key, because if we don't, what we also know is that and this is why advance is important, the later it is in the disease, the harder it is to reverse. So the sooner we can identify it, the easier it is for us to stop it in its tracks. Yeah. So it's a really key aspect. So obviously Litmus was the large European program that was about validating and developing new diagnostic tests, what are called biomarkers for MASLD. That got to the end of its funding on the 29th of February. And there's still going to be even more data coming out from that for at least another year or two. The good news is that we've had another grant funded by the EU, two actually, one called EDC MASLD, which is looking at basically environmental toxins and how they may be contributing to fatty liver disease, but another one called LIVErAIM, which is specifically about taking those biomarkers and looking to see how they can be used to screen in the community to identify disease earlier. So that's going to be going on for the next 6 or 7 years. I'm not leading that one. It's somebody else's turn. So that one's being led out of Barcelona, but we're a big part of it, and it's something that the registry is going to continue to support and going forward with. So absolutely, thank you. A lot of work still going on to that, and it comes down to, I don't want to get too sort of into the long grass about this, but there are all sorts of questions about, it's not just about having a good test, but it's applying that test in the right group of people. Because what's called pre-test probability, in other words, the prevalence of a condition, if you go into a situation where, let's say, 1 in 1,000 people have an illness, even with a test that is 90% sensitive and 90% specific, almost every test comes back positive will be a false positive. So it's about using the right test in the right place. And that's what the work's going on about now.
Thanks. That's an interesting answer. Thank you.
Excellent. So we'll this talk. Oh, sorry, go on, Yvonne. Sorry, I lowered your hand
Sorry.
because I thought you'd forgotten about it.
No, just a very quick one. The resmetirom drug, I know you said it was, and forgive me if you did say it was, are we looking soon to get it perhaps in the UK?
I don't know. I think it'll be a few
Okay.
years, is my suspicion.
Right.
It's really hard to tell, but it has to go through it has to be approved by the regulators. Then there's the question about NICE and payment and all of those sort of things, and that takes time.
Okay.
Mm-hmm.
Okay. Thanks.
Great stuff. There's things on the horizon. It's coming all the time, isn't it? Yeah.
I think that's the thing, John.
Yeah.
You know, we'd have had this conversation a month ago, and I'd have said, "Well, we've got lots of stuff in trial," but you know, at that point, that obeticholic acid had just been knocked back by the FDA. Now we've proved that a medicine can get approved. That's really important, because it also means that other companies developing drugs now know that you can do it, so they're more keen to invest in this area, and that's really important for the field. So this is a hope story, I think.
That's right. That's fantastic. I saw you and Helen Reeves about a month ago. We were at the Catalyst building, and it blew my socks off when they announced that the Newcastle hospitals and the university had been awarded more than any other region for research. And it actually had been awarded £400 million for research, more than any other region apart from London. So I think that's fantastic. There's some great work going on in Newcastle. And then the other thing that blew my socks off was that all of this research is shared across the world without any barriers. When we discover something, when our researchers find something out, they make the findings free to everyone. And it's a bit different in China and Russia and America, but we're very open about it. So that's great. So thank you, everyone. We'll be closing the meeting now, unless anyone has anything else to say. And it'll be available on our YouTube channel in about 12 hours or something like that. It takes a long time to make it fit. So thank you so much, Prof. And it was an excellent talk.
Thank you very much for the invitation. Great to see everyone. Take care.
Thank you.
Right.
Thank you. Great meeting. Thank you.
Thank you. Bye.
Bye.